patients don't know, right? I am very blessed to live in Seattle, Washington, having gone to the University of Washington, where primary care and family medicine in the city and region is more known. But that's not the case for most places. And so patients don't even know enough to be like, wait, there's a doctor. I can't even hear. Like, I have new patients come see me. They're like, wait, you can do this? You can remove my toenail, or you can do this biopsy, this skin biopsy, or, we can do Suboxone here. Like, yeah, we can do all that. It's not that hard. Like, we can do that. But patients don't know that. And if they knew that, I think there would be more of a demand. I think the notion of one doctor doing a good chunk of things, again, not all the things, you got to know your skills and you got to know your scope, but doing a lot of the things, I would say most people would argue like, hell yeah, give me that. Like, I want somebody who I have for 30 years, who I trust. When I trust them as a human being, that they're looking out for me. But two, I trust them as a doctor. They're competent. They can do all these things. Why wouldn't I take that? But most people don't know that. And how can they demand it if they don't know it?
Welcome back to Season 3 of Not Otherwise Specified, a podcast from the New England Journal of Medicine. That's Ben Davis, who directs the family medicine residency at Swedish First Hill in Washington State. In this season, we'll be talking all about primary care. But first, a confession. I didn't intend to devote an entire podcast season to primary care. Basically, I was worried it would be boring, and I couldn't conceive of what we'd possibly discuss across several episodes that hasn't been discussed a million times before. That patients can't get primary care doctors, that PCPs are burned out, that the workforce is shrinking, and that the U.S. healthcare system is badly broken. All true, but the discourse fatigue is real. And I didn't want to go on and on about the crisis of primary care if I didn't have anything new to add. For some reason, I kept imagining opening Spotify, seeing a primary care themed podcast, and choosing to listen to anything else. So what happened? I guess first I wrote about it, which in a sense was an accident too. I was planning to only write about concierge medicine because a bunch of physicians I really admire were leaving traditional primary care to start or join concierge practices. And that seemed like a trend that we should be paying attention to. And then a family friend asked me to recommend a PCP in Boston, and having heard that wait times to get a new PCP at traditional practices were up to a year, I told him that if he really wanted a PCP, he needed to pay for concierge. But as I started to report on concierge medicine, quickly realizing that it was more a symptom of our broken primary care system than some bougie outpost for the wealthy and worried well, I had so many questions. What drove these physicians, some of whom entered the field of primary care because they cared about social justice, to leave traditional practice? If patients were willing to pay a premium for this type of care, could it tell us anything about where traditional primary care had gone astray? And as more patients and physicians flocked to concierge practices in the midst of an access crisis that's only projected to worsen, were we really willing to accept a two-tiered system where the wealthy get to have doctors and everyone else gets whatever's left behind? Or as our producer Mary Rose Madden said to me after one of our concierge medicine interviews, so only rich people get to have their doctors call them back? That didn't sit well with me. Actually, it made me feel a little sick, and it still does, which is how I found myself a bit kicking and screaming, writing about primary care. But once I started, I couldn't stop. I ended up writing 5 essays, which is more than I've ever done on one subject, because primary care, at least to me, turned out to be super interesting. Not because the problems facing primary care are new. In fact, the opposite's true. Primary care in the U.S. has been declared to be in crisis, dying a slow death, for decades. What's interesting, and what I hope to really dissect this season, is why we as a society and as a profession have recognized the crisis for so long, but have done so little to meaningfully enhance its sustainability. And that's why primary care, I eventually realized, was about so much more than primary care. It was about evolving technologies like artificial intelligence that are reshaping healthcare in ways that we're racing to understand. It was about trust, the dissolution of our relationship to society, and the emergence of virtual types of care that privilege ease and efficiency, often over relationships. It was about the rise of advanced practice practitioners, who I'll refer to this season as APPs, and whether they, with help from artificial intelligence or AI, will replace doctors as the future workforce of primary care. And it was about us as a profession and who we want to be. As soon as it became clear to me that our professional identity was baked into the future of primary care, I didn't find it boring at all. And in fact, I realized that the very reason primary care might have seemed boring at first, because everyone knows not only what's wrong with it, but also what needs to be done to fix it, turns out to be exactly why it's so interesting. In other words, if everyone knows what needs to be done to sustain primary care, why haven't we done it? So to get at some of those questions and introduce many of the themes we'll be diving into for the rest of the season, I'll be talking today with Asaf Bitton. Asaf's a primary care physician at Brigham and Women's Hospital, executive director of Ariadne Labs, and an associate professor at Harvard Medical School. And so I started by asking Asaf why primary care has been undervalued for so long.
I mean, at a fundamental level, the U.S. relationship to healthcare is one of a highly transactional, unit-based, episodic view of medicine that sort of privileges the idea that if you're sick, you go to principally specialists and they go fix it, or you have an acute care episode, then it's either fixed or not. And all the other things that make up your health and your healthcare journey, all the other drivers of health, all the contextual factors, all the longitudinal factors, they tend to be subsumed, they tend to be ignored, they tend to be neither clear and present as a focus of reimbursement because we value things as we pay for them, and as a way of fundamentally thinking about the logic of the interaction. Now, the thing that's strange about that is that when you ask people in surveys, what do they want? The vast majority of people put a very high, let's say, non-financial premium, but they put a very high value on having a longitudinal relationship with someone who knows them, their family, their community over time, who can be a trusted advisor, who can deal with the majority of acute and chronic conditions over time and help them coordinate their care journey. I mean, I just defined the core functions of primary care, and most people want them. And interestingly, very high net worth individuals are willing to pay very high amounts of money to get them. So whether you're poor or rich, you value this. But a system in which we outlay $4.5 trillion on mostly acute, episodic, expensive care, and we have a direct-to-consumer sort of model of, if you have a problem, there's a drug for it, go ask your doctor, is sort of at odds with the maintenance, creation, and improvement of a relationship of care, a form of integration, of prioritization, of helping you figure out what matters most. And underpinning all of this is falling relative expenditures in primary care. So as a proportion of the dollar spent, the proportion going to primary care is actually falling at a time when needs are growing. And this is across every payer line, commercial, Medicare, Medicaid, to an average of somewhere between 3.5% to 5%.
Of all healthcare spending.
Of all healthcare spend, yeah.
When I talk to non-PCP physicians, so many look at the state of primary care and they say, we're moving toward a system where all of primary care is delivered by some combination of APPs and AI. And so to me, that suggests a lack of appreciation unless these people actively don't want better health of our population, that they're not convinced, I would think, or they don't think it's valuable enough to invest in a primary care system that continues to be staffed by physicians who are trained to be primary care doctors. So what do you think about both the likelihood of that possibility and also what it would mean for the health of our country?
There are a lot of people outside of primary care who somehow believe that they understand what primary care is, isn't, will be, by reading a couple of abstracts and, making, I think, some pretty facile assumptions on some pretty weak data. It gets to kind of a fundamental sort of underpinning of primary care that, like, it's sort of treated as some sort of combination of simple dumbed down care, a charity case, and something that no one wants to do, which is, again, false on all three accounts and really worth unpacking as to why those memes and narratives get built up at both a training level and a medical professionalization level. But just to take your core point, the sort of people who are watching the transformation of primary care into team-based care that's augmented with technology, initially in the last decade and a half with electronic health records and now with AI, sort of miss the point that that's actually happening all across healthcare. Healthcare is becoming, and pretty much always was, except in our sort of doctor, white coat dominated days, was always a team sport. And now it's being recognized that it must be a team sport to succeed. The idea of replacement is, I think, missing a point of augmentation. Primary care has been so quick to take up ambient dictation because primary care is arguably one of the specialties that is most brought down by the documentation burden and the EHR morass as a kind of focal point of collecting disparate information. So when ambient documentation and soon to be AI-enabled clinical summarization of these massive charts that are impossible to read and find easily, and then soon to be, let's say, AI-augmented diagnostic reasoning, that's a good thing if it proves to be a good thing, as some of the early studies are suggesting. And that it's a sort of, logical fallacy to sort of leap to, and therefore we won't need primary care, because that comes from an attitude of not really understanding what primary care is. If your base case is that primary care is a bunch of people that sit around in an office waiting for people to come in to titrate blood pressure meds and to do vaccinations and take care of sore throats, then yeah, of course you would say something like, I bet AI and an APP can replace that. But if you come to my clinic or our clinics and you see what goes on in a given day, and you're astounded by the range of complexity, where you shift your mind from a social driver of health bisected by three complex chronic conditions with interacting medications and new symptom issues, a new diagnostic quandary, a family conflict, some preventive needs that need to get done, and the fact that you're, let's say in an accountable care contract and you're trying to manage their care and have them not land in a hospital, there's not an AI system that's going to principally replace that.
I think you're right. I think a lot of us don't actually understand what primary care is and does. And I worry that some of that is because we've constrained the work of primary care so much that our experience, even as physicians, either having our own doctors or working with primary care doctors, is colored by the fact that we've made their jobs impossible. And so it feels like we're in a vicious cycle in terms of our value system, which is to say, okay, we made it impossible to practice high quality primary care. So people then see it as sometimes falling short. And then they think that it's therefore not valuable, which doesn't help our value system in the first place.
I think that that's right, by the way. And I think that beyond that, there's a sort of hierarchy of knowledge and influence. And when you have a surprising number of well-known, well-regarded medical schools, including Yale, Harvard, Johns Hopkins, and others, that don't have full-fledged family medicine departments, family medicine being the principal specialty of primary care in terms of numbers and academic output and membership across the US. So you're sort of looking at a situation in which the hierarchy of knowledge and reputation is not just notional, it's actual. And then yet there are, again, idiosyncratic reasons why this is the case. And it's not an accident. It's part of a whole sort of way that primary care gets mislabeled, misinterpreted, misallocated, misreimbursed, because it's not seen as an equivalent in the tower of medicine.
Yeah, so I think that is as important, if not more so, than this idea that we need to address the payment system, which we do, but that feels to me like the tip of the iceberg, and that the reticence, the inertia within the profession, the inertia among policymakers. I don't think I want to say there's inertia among the public, because one of the more puzzling things about this is what you said earlier, that the public wants to have primary care doctors and somehow their will isn't heeded.
Right.
But we're still left with this devaluing that is decades in the making. And it's not, you said it's not an accident. So it's not intuitive to me that the people who have to know the most about so many things and play a role in someone's life over a lifetime, rather than, say, like taking out an appendix in a discrete episode, are valued the least. So how did we get here? And are values malleable? Like, can we, because that feels to me like if we can't address this hierarchy, if we can't address this value system, then we're stuck.
Yeah. I appreciate your question, and I think you're right that this is more than payment, and there's part that was an accident and part that is deserving of a lot of good observation and reading of what happens. Is two things. Number one, the scope of what we can do grows massively, and the places where we can do it get localized, built up, have higher sort of baseline running costs, and the machine needs to be fed, in essence. But number two, as an ethos, as a profession, we start to sort of see medicine as this great scientific, empirically driven, increasingly subspecialized body of information and group of people. And those are all really good things. Everything is fine here. But, and this is, I think, the points to detangle, within the locations where the formation of professional identity occurs within medical schools and their hierarchies and their professionalization of activities and what's valued and what's counted, papers and grants and sort of professorships, etc., that becomes atomized. And moving to the side and probably slow to catch on, if I'm being sort of critical of my discipline, is the concomitant sort of scientific medicalization of primary care related specialties. Also at that time, the NIH becomes a massive funder for medical schools and their derived outputs, papers, successful grants, professorships, etc. And the NIH spends vanishingly little on primary care related disciplines in health services research. So over, let's say, 40, 50 years, you get a sort of medical school, scientific funding, specialization complex that probably is no one's fault per se, no one planned it, but essentially shunted the community and primary care sciences and fields and disciplines, reduced the number of people going into them as remunerated professions that could be easily codified within fee-for-service, and CPT codes kind of went up as Medicare billing changed. And all of a sudden you get to where we are now, where, primary care specialists per se, the people who do primary care have a relatively narrow window and type of services that they can bill for that do not encompass their work and that are remunerated at way lower levels, in large part because of pressures within congressionally mandated Medicare physician payment, which is neutrality. You go up for one type of services, you have to go down for another. And when the committees that advise Medicare on how to judge whether payment rates should go up or down are 29 to 4 specialists versus primary care. And 85 to 95% of those recommendations are taken up by Medicare. It starts to make sense how this change in professional attitudes, training norms, and academic means, and combined with scientific investments, combined with payment changes over time, have served to kind of push primary care into a corner as something that's not all that scientific, which is wrong, and not all that important, which is wrong.
Part of me felt optimistic for the first time in a while about primary care listening to you. And the reason is that, again, assuming that we care about what society wants and thinks, and obviously we should, in some ways it seems like primary care is on the cusp of having a moment. And by that I mean people clearly feel over medicalized. They're mad at drug companies. They're mad at the institution of medicine. They're mad at the transactional nature of all care. And if anything can address some of this anger, this institutional distress, this feeling that all we do is throw drugs at people, that we in fact invent diseases so that they'll be forced to take drugs because we're all in bed with the pharmaceutical industry, etc. Primary care has like an opportunity to like step up to the plate, because so much of what you do is the antithesis of that. I guess then the next question is, where is the disconnect? The disconnect is probably vast, but it seems obvious that, for instance, we need to address the way that primary care physicians are paid relative to other physicians. And yet, knowing that, I know that, I assume you know that, maybe that's not your top priority, but I'm sure you wouldn't mind it. Why, given that we know that, given that we want more people to enter primary care, given that we want people to have access to doctors, why don't we do it?
Well, it isn't really a health policy debate. It's not like there's one camp, Lisa, and, they're the pro-primary care camp, and then there's another camp that sort of isn't clear that the evidence is there for the value of primary care or the values around primary care. I mean, this is an open and shut debate. It's almost as close to a health policy law as one gets. There's no really well-performing health system that one can point to in the US or in the world. And by well-performing, I mean good outcomes at a reasonable cost that take care of the needs of its population. There's not a single one that one could point to that doesn't have a strong basis at its foundation of primary care. So if that's the case, then, if this is not a debate or more evidence is needed kind of thing, then what is going on? And it is a combination of a problem within the House of Medicine, writ large, within what we value and what we ask to be paid for, and with the people, entities, payers and purchasers and government entities that pay for it. We choose to reduce the proportional spend on primary care. We choose to think that while some people give lip service to recruiting more primary care clinicians, we think that that's possible while their non-primary care peers get paid 3x, 4x, 5x. We choose to sort of nickel and dime primary care teams for every additional FTE in the practices as they take on a more expansive scope of preventive, promotive, chronic, and acute care, behavioral health integration, et cetera. And then say, well, maybe we don't have actually the funding for an FTE social worker or a nurse or something like that. We ask kind of almost absurd criteria of evidence of, quote, ROI or impact. Like, every time a payer is considering whether they're going to invest a little bit more in terms of their falling investment in primary care, they come and they say, well, what's the 18-month ROI? But they have no problem investing in new PET scans. They have no problem investing in new GLP-1s, even when the ROI on a GLP-1 is probably about the same as an ROI on primary care, maybe 10 or 12 years before you'll start to recoup your investments. I'd bet on primary care way more than I'd bet on a medicine. But we somehow think that primary care has to be both under-resourced, quiet, in its place on the bottom of the hierarchy, but somehow produce the amazing outcomes that it does and be there for when people need it, all at a cost or an incremental cost if we add in a few resources that pay for itself. Whereas we never ask for other specialties or other cancer service lines or cardiology service lines or surgical service lines to have that bar of outcome, efficiency, and outcome per dollar extra spent.
Right. No, it is an absurd double standard. I mean, I've never heard anyone say like cardiology ought to save money for the system, but for some reason people say all the time primary care has to be cost saving. So that's never really made any sense to me.
58 minutes ago, I was on a call where that statement was said by a set of payers and sort of national bodies. And I said the same thing that I'm saying to you now. Why don't you have that same level of expectation for every other service line? Or for the $77 or $80 billion that you invested as an industry in a new class of medications, GLP-1s, which are game-changing for many people. But we didn't have the same conversation. We had a conversation about prior authorization. We had a conversation about the right purchasing price, but we didn't have a conversation on when is the investment, the incremental investment, going to pay itself back. But we do have this for primary care. So it's at best a source of a great blind spot. At worst, a kind of enormous misspecification or frankly illogical argument about what it is that we're supposed to produce through our health system.
I want to go back because I think if I could say that something terrifies me, that sounds like a bit of an exaggeration, but kind of does terrify me. And that is that we are losing really talented trainees to either hospitalist medicine or subspecialization or something outside of internal medicine entirely. And I feel like primary care, in a sense, is kind of like the epicenter of a lot of the pain in medicine because primary care doctors, I think, are the most abused. I think they are legitimately morally injured. And I say legitimate because I think that they are asked more than the rest of us to function in a system that doesn't support their work at all. And so, you and I have spoken before a little bit about the training pipeline. And I know that some of it is that funds are misallocated. But there's also something very visceral, I think, in terms of looking forward, seeing how unhappy people are, and then saying, yes, sign me up. Right. I want to do that. So
and I want to do that for a third of what she'll get when she grows up, right?
Exactly. So why would anyone go into primary care?
Well, I think that what we see in our trainees, what I have observed in the trainees that I've worked with, plus what I've read in the literature from both the quantitative and qualitative literature, is that a lot of trainees come into medical school increasingly because the standards for getting into medical school in terms of the construction of the MCAT and what required classes have undergone a gradual but important shift, widening the aperture to social and behavioral sciences, asking questions about statistics and public health related capacities and aptitude on the entrance process. So why do I bring that up? Because I think that we're getting increasingly more of a substrate of candidates who want to or would want to go into primary care. And I've often said we have to find ways to help them give themselves permission to do so. So that, number one, it's not a completely economically irrational act, because asking people to do what's against their bottom line means that primary care is more of a charity case, right? That's not an improvement methodology, is to think of this as like a sad sack, left behind where people do, God's work to help others. I mean, that's not an improvement strategy. So if people are coming in with the mindset that they're open to doing work, which let me just tell you, I think primary care is, I don't know how to tell someone, is it better or is it worse? I think it's amongst the most intellectually thrilling, fascinating, important, rejuvenating, life validating pieces of work that I've been a part of or could think of. I mean, it may be hard, but those of us who stay in it aren't idiots either. I mean, it's great work, and to take care of people in a comprehensive, longitudinal way for the majority of their health conditions, and to see the wild variety that is primary care medicine, it's like a front row seat on life, and it's amazing. So how do we keep people from being too discouraged and making it an act of insanity to do what is actually an amazing thing? And let me just say, it's amazing medically, but it's also, some of the most important things that we do in primary care literally enable people to lead better lives and comfortable lives tonight. Case in point, and this is maybe a crystallization of some of the kind of problematic thinking that goes on in medical education. A lot of people look at some of the things that we do, in our dealings with social drivers of health, and they say, what a mess. Like, how stupid is that? You're talking to the heat company about keeping the heat on. Let's unpack that for a second. Yeah, I talk to heating companies all the time. I issue letters to help people not get evicted or to keep their housing or get transitional housing, get food stamps. I can argue very well that is life-saving work that makes someone's life better tonight. Keeping the heat on when it's 10 degrees outside, that's a good thing. Helping them get food when they're hungry, that's textbook answer for what to do for malnutrition, right? It's an immense privilege because someone endowed us with MDs behind our name to literally issue letters and to fight with people, a good fight, and help people, and that's why they come back to us. I don't think that's stupid work. I mean, it's more complex work than dealing with some of the fairly protocol disease treatment algorithms. It takes creativity, it takes buoyancy, it takes energy and aptitude, and you're doing good work. So my point is that we might want to flip around the narrative that, because you can make a very specialized diagnosis, because you can cut something out or zap and map something in the EP suite or do a fancy scan, that's awesome. And people need that. But that's no better or worse than us keeping people's lights on. And it's all important. Maybe a little bit more humility, I think, on everyone's part, and a bit more of a kind of systems or holistic look at what creates, maintains, and promotes health would do us all some good in helping us understand what we spend our time, money, and effort on, and maybe what we don't, in terms of, I think, what's a common shared endeavor toward improvement.
I can't help but think that as you speak, I mean, you're facing the same constraints that others are facing. And some of what you're talking about comes down to a belief that you can make a difference, that if you call the heating company and say who you are and why this is necessary, that a change will come. And there's something about that I think just gets back to this theme that I keep pressing on, that there's more to this than the finances and policy changes and structure. There's a narrative about primary care. And that narrative is so negative. And it is, in some sense, and I guess I talked about this in the training series, and I'm talking about it in a different way now, but the narrative about moral injury essentially can become this self-fulfilling prophecy where you're so convinced that you're not able to do your job, that you don't see all those quiet moments, like when you can. And you seem to just like actively defy that on a moment to moment basis, both in the way that you take care of your patients, and I know how you take care of your patients, and also in the work you do. But I sense from you that you're more optimistic than others, not just about what you can do on an individual basis, but about the future of primary care. And so I want to hear why you're optimistic when the rest of us are going, this specialty is dead. And you're like, no. Tell me why no.
First of all, it's not just me. I think there's such wisdom in what you say about the necessity of putting an accurate label and definition on something like burnout and moral injury, and the care we must take to not make it a self-fulfilling prophecy or fallacy. The fact is, I'm not really any more special than the hundreds of thousands of other primary care clinicians who wake up every day and go do their job. And yeah, they're hurting, but they're not going to quit tomorrow. And they weren't going to quit yesterday, and they're not going to quit in a year. We'll have workforce challenges. It'll go probably down more before it goes up. But there are real reasons, and not just sort of like optimism for optimism's sake. But first of all, it's so important to know, and I think you've hit upon it, there's a sort of strategic perseverance to primary care that I'm not in a position to say is or isn't in other specialties. I just know my specialty, and I know the people that I work with, and I've had the privilege of traveling around the country and around the world in both research and policy capacities to talk to a wide variety of people doing this work, and they're pretty consistent. And they're consistent whether they're on one side of the political spectrum or the other. These are hardy people who want to get the work done, who see the value of some of the things I just told you about, and aren't going to let the sort of conventional wisdom just blow them by the wayside. That's reason number one, I'm optimistic. Reason number two is I'm a sort of amateur historian. The death of primary care has been prematurely foretold for probably about 60 years now. If you go back and look at the elite medical literature, it's been foretold for different reasons, reasons that range from lack of utility as we all become subspecialists, which didn't come to be the case, a lack of recognition for the need for integration and a holistic view of care, fanciful excursions and diversions into the worlds of management literature, suggesting that everything can be optimized and boiled down to sort of Taylor-esque managerial improvement standards, which again, probably can only optimize a third of healthcare. 2/3 remains much more complex than a factory floor. And it's been foretold now because of the rise of AI, or 5 years ago, the rise of health tech startups. And every time it gets foretold, it misses a fundamental thing, that most humans are looking for relationship in their healthcare journey. They're looking for a trusted advisor. They're looking for someone who knows them over time and who also sees them. They're looking for the property of being seen. And when you go in to a rushed, atomized interaction that does an amazing technical job of removing your skin lesion or treating your heart condition or your oncology episode or what have you, you get one part of what you're looking for met. But the decision as to whether you should have even gotten the screening test or the diagnostic test that might or might not diagnose a complex oncological issue or rheumatological issue, someone had to make that diagnosis. It wasn't the rheumatology or cardiology or oncology clinics. It was primary care. And someone probably made that diagnosis because you had a relationship with them. You entrusted in them and felt seen by them to be able to come and say, I feel a lump somewhere. I am worried about this. I have noticed that. I can't seem to this. And that person who knows you and trusts you and saw you, including your record, but not limited just to the technical things in your record, who saw you as a person, or who sees that there's a change in you compared to 2 years ago, thought and integrated and articulated a diagnostic and relational strategy to take upon with you the next steps in your healthcare. Or maybe you're at the end of an episode in which you're at the end of your life and you want to entrust that person with the privilege of asking them, what should I do next? Or where should I go? Or how do I figure out what's important? Or how do I figure out how I want to die? You don't get asked that question unless someone has earned that privilege, and someone doesn't earn that privilege unless they walk with you in a beautiful, complex, sometimes challenging act of accompaniment over years. That is beautiful work. That is necessary work. That's the work that a health system requires to not totally spin off its axle. which it would if there were no integrating function that met the needs those three things I just laid out, and a litany of others. And so every time this clever new person comes and says it's the death of primary care, those of us in primary care say, yes, and maybe, but probably not, because unless you show me where those needs, functions, and journeys and accompaniments are going to be met, maybe it'll be a little harder next year, maybe it'll be a little better, but we'll still be here.
Obviously, that's what I hope, but I can't tell whether I'm one of those people who thinks I'm more clever than I actually am, prematurely foretelling the death of primary care, or whether we really are at an inflection point. And so that's what we're going to be talking about for the rest of the season. Is primary care actually dying? Does it matter if we end up with a primary care workforce largely composed of APPs with AI augmentation? And if it does matter, what collective responsibility do we bear as a profession to stop the emergence of a two-tier system where the wealthy can pay for physician access and everyone else gets whatever's left behind? In the next episode, we'll be talking about what seems to be on everyone's minds: artificial intelligence. How is AI being used in primary care right now? What are the risks? And can AI actually make primary care more sustainable?
It's not really about knowing a lot of medical knowledge anymore. It's about how to interpret what the AI gives you in the future. And so as AI gets more sophisticated, a lot of the analysis, a lot of the differential diagnosis will become increasingly dependent on AI in one future. And what is the role of the human clinician then? Brave new world. Nobody really knows.
I'm Lisa Rosenbaum, and this is Not Otherwise Specified. Our editor is Debbie Molina. Our producer is Mary Rose Madden. And I also want to thank all of my colleagues at the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. They've helped me to conceptualize the season and to identify the most pressing and unexplored challenges facing primary care. My new article series on primary care can be found at nejm.org.